Okay, so thanks everyone for attending the workshop, the seminar today. So it's really my privilege to represent QBIC, to invite Paul Crosland to be our guest speaker. So today, Paul will share with us one of the study within a bigger study of youth mental health at the Brain and Mind Centre at the University of Sydney. And the topic today is about the health and economic value of improving the social determinants of mental health. And I would just like to share before I introduce Paul that this study has been published in Nature Mental Health. Am I correct, Paul?
Yes, just I think last week or the week before.
Yep. So it's brand new, hot off the press. So yeah, congratulations to Paul, but also I think we were in for a treat. So before we start, I'd like to introduce Paul, hopefully. So I've known Paul for a long time, and I can speak for about 2 hours about how fabulous he is. But as an introduction, I just summarize that Paul is a very experienced health economist, and at the moment he's in his final year as a PhD candidate at the University of Sydney and at the Brain and Mind Centre. He has about 15 years of experience in health economics and working across the space of government and academic role in both the UK and Australia. His training is in economics, public health, and simulation modelling. And over time, he's developed a very large portfolio of applied economic analysis, as well as simulation models that influence health policy and inform government decision-making. So at the moment, Paul's primary research focuses on youth mental health care, and system strengthening. And today, he will be sharing one of the passion of his research around social and economic value of mental health. His work also applies system dynamic simulation modeling to identify strategic evidence-based and cost-effectiveness investment in treatment services and policy. So I guess one of the reasons that I was really interested in inviting Paul to give a talk today is because I've seen the direction of QBIC evolving in the past 2 years. And I think having strengthened our capacity to understand how to incorporate system modeling as well as a long-term model for economic evaluation as well as implementation, and how to actually work with decision makers as well as lived experience is very key in this process. So I hope that you will really enjoy Paul's talk, and hopefully we will have plenty of time in the end to have some question and answer. So I'm gonna stop sharing now, and then I let Paul to share.
Thank you very much for that nice introduction, Kim. I'll just get my screens set up. Okay, so thank you very much, Kim. Thank you to the rest of the team, Fatima, Margot, and the rest of the team for inviting me to come along and speak to you today about our research on the economics of mental health. So today I'll be speaking about an analysis estimating the health and economic benefits of improving the social determinants of health. And like Kim mentioned, this is one of the outputs of a larger project called the Right Care First Time Where You Live project, which is working with 8 regions around Australia to develop simulation modelling decision support tools that help us apply systems thinking and help guide investment decisions to improve youth mental health all around Australia. Before I begin, I would like to acknowledge the traditional custodians of country throughout Australia and their continuing connections to land, culture and community, particularly the Yagara and Turrbal people, who are the traditional owners of the area now known as Brisbane, where I am at the moment. And I pay my respects to elders past, present and emerging. So first, I'll start off with a little bit of background about mental health and what we mean when we talk about the social determinants. Many people here would already be familiar with why this is an issue in Australia, so I'll just touch on this briefly. Australia has the highest rate of mental health-related health burden in the world in terms of disability-adjusted life years, and it accounts for 12% of the total health burden in the country. Suicide is the leading cause of death in younger people, and close to 20% of the population fill at least one mental health-related prescription in the space of a year. There's also a socioeconomic gradient with those at more disadvantage, likely to experience anxiety disorders and suicidality and self-harm compared with more advantaged populations. And there's some differences between the sexes and the ages. Although mental health issues, particularly anxiety, are experienced at a higher prevalence in females, suicide deaths and self-inflicted injuries occur more frequently in males. And when it comes to age differences, there's mental health has deteriorated quite substantially in young people over the last 10 years. And this is important because it's a key period for diagnosis, for treatment, for prevention, and that's because 75% of mental disorders emerge before the age of 25. The Hilda study is one example of the data that we have on this, and that found that depression and anxiety increased substantially since 2009, as you can see with the red dots on the right there. And so the COVID period was just a continuation of this already upward trend. As you can see on the left, one of the consequences of this prevalence are relatively high rates of self-harm hospitalizations in younger age groups, particularly females. And there's a lot of talk about the uptake of devices and social media being the cause of this over this period. One example being Jonathan Haidt's book, The Anxious Generation. And no doubt this plays part, that it's part of the story, but I don't think it's anywhere near the whole story. And I think that maybe social media may simply serve to amplify some of the real root causes of the economic and the social and the cultural systems that produce an environment that's not conducive to mental health and well-being. And that's what we'll be speaking about today. Along with this health burden, there's also an economic burden. There's $12 billion spent on mental health in the space of a year, which ranks at 5th in terms of expenditure, and this has been increasing each year. Now, increasing expenditure isn't a problem per se, and it can actually be a good thing if it's being spent on effective and cost-effective treatments and services and prevention programs. However, there are studies suggesting that current resource allocation is far from optimal, and the National Mental Health Commission is one entity that recognises that there's little data on the effectiveness of the money that's currently being spent on mental health care. Now, in terms of that increase, it may have been increasing in absolute terms, but it's actually remained the same as a proportion of the total healthcare budget. So that's a bit of a problem in itself when you compare that to the increasing health burden that I spoke about before. Taking a broader view outside of the health sector, the Productivity Commission has estimated there's an additional $70 billion worth of productivity impacts. So to summarise all that, we can see that there's a clear need to do something different. And I think that more economic evidence would be useful in informing these future investment decisions in mental health. Now, there's a range of different solutions that are being proposed to address the problem, some of which are actively being implemented. So, for example, there's improving access to services through more headspace centres, or subsidising Medicare-funded services, consultations with mental health professionals. There's more adoption of clinical staging and measurement-based care as more personalised and transdiagnostic approaches to identify where clients currently sit on their illness trajectory, and customising treatments according to this, basically trying to make treatment more personalised and customised to where people are actually at. And there's also innovative medicines that are being introduced to Australia and at various stages of regulatory approval, like esketamine or psilocybin-assisted psychotherapy for treatment-resistant depression. But there's a growing recognition that broad, population-wide improvements will probably only be achieved by transforming the social and economic systems into ones that foster good mental health as the norm rather than the exception. So I think here we're talking about changing the environment in which we live to one that prevents mental disorders before they occur, and also fostering an environment of recovery that supports the effective treatments. So here on the screen, I've got a small sample of some strategic documents that highlight the pivotal role of social determinants. Firstly, we've got a couple of Lancet commissions that have been published in the last couple of years that highlight the importance of social and economic determinants. The National Mental Health Commission clearly states in their national report card that nothing will change, or it could actually get worse if we don't focus more on social determinants. And the recent review of the National Suicide Prevention Strategy specifies many social determinants as key objectives in any prevention strategy. So what are we talking about when we refer to the social determinants? Well, they refer to the social, the economic, and the physical environments that directly influence the incidence and the prevalence and the severity of mental illness. And I kind of like the diagram that we've got here because it links the social and economic determinants to the UN Sustainable Development Goals. And it conceptualizes how the social objectives that we've committed to as a global community line up with the environment and the society in which we live, which then interacts with epigenetics and individual risk factors that all come together to result in the actual mental health condition as it's experienced by an individual. And so some examples of the structural risk factors that influence mental health include education, unemployment, poverty or financial insecurity, food insecurity, unstable housing, social isolation, loneliness, childhood adversity, neighborhood conditions, and those could be physical or social. And these kinds of things often have bi-directional relationship with mental health and can be interlinked with each other. They can be dynamic and change over time. And there could be a complex causal web working here. And so I think this highlights the importance of systems thinking when we develop strategies to try and improve these social determinants. And just like the experience of mental health conditions and outcomes themselves, most of these risk factors and determinants are also associated with a social gradient, where the greater the inequality, the greater the inequality in risk. So what evidence is there that these social determinants cause mental illness? Well, there's a few systematic reviews that are available in the literature that summarize the current evidence. This is just a sample that I've got here. And to summarize, and at the risk of oversimplifying the evidence base, I mean, you can imagine how varied the evidence is when you consider the vast array of determinants that we're talking about here. There are a few themes that start to come out of the systematic reviews. And I think that's that there is strong evidence for the links between financial security or poverty and mental health, having employment and meaningful work and job security, community and neighbourhood social cohesion also is supported by the evidence. And there's also strong evidence for social connection for young people, whether that be directly with peers or in a school-based environment or with their own families. And there's also lots of strong evidence for the importance of early life adversity or childhood trauma and subsequent mental health issues later in life. There's also some less evidence, but at varying stages for education, green space or built environment, discrimination, digital devices and social media, and also food security. And that's not to say there's no evidence on these things. It's just not as strong as the other 5 elements that I mentioned before. So in the context of a constrained budget environment, choices have to be made about where resources are allocated, but it's hard to know which changes will deliver the greatest mental health and economic benefits. And that's where systems modeling tools or simulation modeling can help. And these are useful because they combine a whole range of different types of data from different sources into a single place. So they combine demographic data, social risk profiles, mental health evidence from the literature, all into a single platform so that we can estimate what happens when different parts of the system are changed. So they act a bit like a flight simulator for policy. Governments can test different investment strategies, different ways of changing the system, and see what outcomes that has before committing real resources towards those things. So let's have a look at an example of using systems models for these social determinants. So the objective of this analysis was to estimate the health benefits and the economic value of improving a set of social determinants of mental health in the Brisbane South region using system dynamics modelling. There were 8 social determinants included in this analysis. You can see the list there. And we improved each of these determinants individually by 5% or 10%. And these were hypothetical improvements. So what a 5% improvement means has a specific definition for each determinant, but generally it involves a small change to the yearly rate of change rather than an absolute change in that determinant. So one example, if we look at social cohesion, that's actually been declining for many years in Australia. And so when I refer to a 5% improvement in this analysis, that means that social cohesion is still declining, but at 5% less than it otherwise would be. So in other words, we've kind of tried to model more realistic and achievable improvements to the social determinants. The main outcome of interest was incremental net monetary benefit, but we also report disaggregated health outcomes in terms of quality adjusted life years, suicide deaths avoided, ED presentations, self-harm hospitalizations avoided, and the costs are reported for both the healthcare perspective and the societal perspective, where the societal perspective is more broad. It kind of encapsulates costs that are incurred outside of the healthcare system, like homelessness services or criminal justice costs, for example. And another big factor, another big differentiator for the societal perspective is productivity is included in there, but not in the healthcare perspective. This was the process of stakeholder engagement. There's 3 main big workshops where we introduce the process of systems modeling. We provide a draft model structure in the second workshop and talk through the different interventions that we want to include. And then in the third workshop, we provide the model to the stakeholders, and there's an opportunity to test drive the model, try and break the model, see if it's producing any counterintuitive results, and if those counterintuitive results can be explained in some way, or if it's highlighted a bug that needs to be fixed. There's also several expert advisory committees that meet on a more regular basis, and that helps us with the more detailed aspects of developing the model and the structure and input data, and identifying the best sources of data to populate the model. And it also has an interface, so stakeholders can use the model once it's complete, and training is provided for this. This is an overview of all the different sectors that are in the model and the interactions between them. And the social determinants and their effects on other parts of the system are informed by a wide range of sources. So social cohesion, when that's improved, that affects the onset of high levels of distress for all age groups, including childhood difficulties. And then that in turn affects the calculation of quality adjusted life years, because that's based on the different distressed health states. And then this also flows on to indirectly impact other parts of the model, such as the perceived need for services and people going to mental health services to seek care. The influence of social cohesion on distress was calculated using a technique called constrained optimization. The reason that we did this was, although we do have much evidence in the literature on things like social connection and loneliness, optimization is used in this instance due to the adoption of a broader measure of social cohesion. And what this optimization process involves is testing many combinations of parameter values, constantly moving the model towards a better fitting solution so that this minimizes the calibration error across all the sectors of the model. And I'll show some slides on that calibration process soon. Moving on, childhood difficulties. That measure was based on the Strengths and Difficulties questionnaire, which is kind of serves as a proxy for trauma and other adverse childhood experiences. And when we improve childhood difficulties, that reduces the onset to higher levels of SDQ distress categories, and therefore that also impacts the calculation of quality adjusted life years. And once again, that also indirectly flows on to other parts of the model, like perceived need for health services. And the original rates of moving between the Strengths and Difficulties questionnaire categories was from the longitudinal study of Australian children. Homelessness, when that's improved, that reduces the risk of moving into higher levels of distress. There's also some costs that are directly linked to homelessness. And the links between homelessness and distress were informed by the National Study of Mental Health and Wellbeing, as was unemployment and underemployment. We also had some additional information in there from the literature. With discontinuing secondary education, so when we improve the participation in education, that flows through to a special measure we've got there called NEAT, which is not in employment, education and training. So that can be a useful measure for decision makers in and of itself, but that then flows on to other things like substance abuse. Substance misuse is the final social determinant that we've got in there. It directly affects suicidal behaviour and distress, and there's also some costs that are directly linked to substance misuse disorder as well. So in summary, some of the determinants have quite a direct influence on quality adjusted life years through turning up or down the levels of distress, whereas others have more indirect effects on psychological distress. So when we interpret the results, I think it's worth considering a range of different cost and health outcomes to fully understand the impacts and prioritizing the different determinants depending on what the main objectives are for the decision maker. And we can also get a sense from this overview that changing one part of the system has indirect effects on changing other parts of the system over time. So that previous slide was a helicopter overview of the model structure. Now this is an example of how things are working at the atomic level and the stocks and flows that are involved. Stocks and flows are the basic building blocks of a system dynamics model like this. And the focus that we've got here is the stock of people aged 18 to 24 with a disorder and also experiencing distress. And people can enter this stock, as you can see by the arrows, the flows leading into the square stock there. People can enter that by aging from the younger age groups at the same distress levels, or they might be the same age, but worsening in distress. There might also be net migration that brings people into the region at that existing age and level of distress already. and there might also be suicide deaths that are avoided due to an intervention. People can leave that stock, that group of people, by getting better and moving to a lower level of distress within the same age group, or they could stay at the same level of distress and get older, or unfortunately they could also die according to risk-adjusted mortality. So this process is replicated for all of the age groups, for all of the different distress levels, and this makes up the psychological distress sector. All of the other structures based on this stock and flow approach and replicated for all of the other sectors that we saw on the helicopter overview. And this being just one sector, you can imagine how large and complex the entire model structure is. Once you add in the healthcare services and the costs and the interventions and the economic calculations. But each of these sectors is are stepped through with the model development group, with the expert advisory group, each time we go through one of the sectors. All of those sectors are calibrated to historical data to ensure validity and consistency with the past data. So here the blue line represents what the model is producing, and the red line represents the actual historical data. So we want to get those lines as close together as possible. So this is for the population sector, and these examples are for GP consultations and specialist mental health services. And this process is replicated throughout the model. We obtained a whole range of costs from a range of sources, all of which were transparently shared and confirmed with the model development group once again. The standard time frame that we used was 11 years, but we also had 3 years in there as well. And we discounted costs and quality adjusted life years at 5%. Okay, so that's kind of the background and methods. Let's have a look at some results. All of the graphs that I've got here are for 5% improvements in the social determinants. Here I've got incremental quality adjusted life years. So what we're showing here is the difference between each of the scenarios of improving one of the social determinants and business as usual, or the current state of the world. So this is reporting that incremental difference. And what this is telling us is that reducing childhood difficulties results in the greatest improvement in quality adjusted life years. And I guess this is to be expected considering that these distressed health states are directly linked to the calculation of QALYs. And so the improvements earlier in life tend to flow on to older ages. It also tells us that improving social cohesion is ranked second in terms of QALYs, and but all determinants resulted in some improvement to quality adjusted life years to one degree or another. Here we're looking at costs. This is the incremental cost for the health perspective, so we're just looking at healthcare related costs here. Negative figures are a good thing, and that's because it represents cost savings. And what this is telling us is that childhood difficulties and social cohesion are again a feature with some of the biggest impacts, but homelessness is also highly ranked here, and that's related to the additional costs that are directly linked to homelessness in our model. Here we have costs again, but this time for the broader societal perspective. So this is where productivity comes into play, along with a few other cost categories. And what this is telling us is that unemployment and substance misuse are quite highly ranked for this measure in terms of cost savings. Here we've got a measure called incremental net monetary benefit, and this is for the societal perspective. And this is where we bring the health benefits and the costs together in a single measure. And we do that by a process called monetizing the health benefits, using a willingness to pay for each additional quality adjusted life year. And that's a fairly common thing we do in health economics. But it's a useful measure because it includes all of the health benefits, all of the costs, in a single measure. And this tells us that substance misuse, childhood difficulties, social cohesion, and unemployment were ranked in the top 4 for this measure. Just an important caveat for anyone that's used to seeing economic evaluations. This one can't be interpreted in exactly the same way as it would be for a normal economic evaluation because there's no interventions included here. So it still provides us with some important information, which is the overall economic value of the downstream cost and health consequences, just without any attempt to compare this to how much it would cost to achieve those improvements with a specific intervention. Here we're focusing on the health outcomes according to various measures. Childhood difficulties and social cohesion are again highly ranked when we consider intermediate measures like ED presentations or hospitalizations. And substance misuse also achieves meaningful impact on suicide deaths avoided and hospitalizations. But just keep in mind that this is for one local PHN's geographic catchment. So South Brisbane accounts for about 4.5% of the Australian population. So the effects are likely to be much more substantial if you scale this up to, say, I don't know, the state or the national level for a model that was hypothetically developed for that purpose. Summarizing all of this into that incremental net monetary benefit measure allows us to estimate the general value of these small improvements to social determinants over time for both the 5% and 10% hypothetical improvements. And here we can see the importance of taking a long-term view when considering investments in social determinants. And that's because much more value becomes apparent by 11 years compared with 3 years. So in summary, even modest improvements to social determinants can accrue meaningful health and economic outcomes over time. This work adds to the evidence base on the economic credentials of moving upstream to target the underlying causes of mental illness. I think it tells us that social cohesion, childhood difficulties, substance misuse, and unemployment are a group of social determinants that could be prioritized on the basis that they're forecast to improve both health improvements and reduce costs. And this exercise was also useful by demonstrating the use of a systems-based simulation modeling tool that we can develop with local communities, and they can use it to aid their decision-making, and they can also use it to advocate for funding for these types of initiatives from higher levels of government. And these findings are generally consistent with what you see, the evidence base that you see in the literature on things like the links between unemployment and suicide, the influence of early life circumstances on mental disorders in later life, the importance of social connection for mental health and well-being, and also the association between substance misuse and mental health challenges and cost. There are, of course, a few limitations with the analysis. Firstly, specific interventions were not included, so we can't say whether it's cost effective to pursue these improvements without knowing the precise cost of the actions required to achieve this. And linked to that, the 5 and 10% improvements are hypothetical, but they're also not necessarily unrealistic either, and they could easily be adopted as government says, strategic or aspirational targets to aim towards. The third limitation is that there's many social determinants that we didn't include in the analysis. So there may very well be other ones that have bigger impacts than the ones that we've got here. Examples could be financial security, food security, green space and the built environment, and also social media. As with any model, we need to be mindful of the strength of evidence that underlies the association between the determinants and the target sectors of the model, whether that be derived from ABS data or studies from the literature. And finally, in most economic evaluation, we'd prefer to do a lot more uncertainty analysis than what we've done here. And that allows us to know how confident we can be in the results. Although we did conduct some limited sensitivity analysis on, the degree of improvement and also different time horizons, we also tested utility values and a few of the costs. It's still lacking that full, broad, comprehensive one-way sensitivity analysis and also something called probabilistic-based sensitivity analysis, which, and I think the utility of those things is a little bit limited when you're talking about the hypothetical changes here, but it certainly becomes much more important in the future when we do include interventions in this model, and you do want to know about how certain you can be in your conclusions about whether an intervention is cost effective or not. For people that are interested in reading more, it's now available in, it's now been published, and you can obtain that there. I've got the QR code. The QR code on this screen is the same one as the previous screen if you missed it. So where I think this could go in the future is, of course, the most obvious thing is including specific interventions, so that we can target social determinants with and working out whether those are cost effective. I think there's also an opportunity to include additional determinants in a model like this. Like I mentioned before, in the limitations, I think we can do much more comprehensive uncertainty analysis, particularly the probabilistic-based stuff. And I think it would also be interesting to broaden the methods and the measures that we've got in here. Say, for example, representing health benefits in a way that moves beyond the quality adjusted life year to, say, for example, trying to account for people's capacity, which is a different conceptualization of health, or their well-being using some various well-being measures that are out there. I think there's also an opportunity to include a more complete picture of productivity, particularly around unpaid work like volunteering, for example. And we haven't got the health outcomes of carers in this model due to some, this is a rapidly evolving space in the health economics field when it comes to how to include the health of carers, but it's something that we'd like to try and include in a future iteration of the model. Just to, in the final minute or two, I just thought I'd mention some interesting stuff on interventions. There's a few, and the kind of things that we're thinking about including in the future. It's a bit of a mixed bag when it comes to interventions that are supported by the evidence, and there are some systematic reviews available in the literature. This is me cheating and using AI to synthesize those systematic reviews into the top 5 that are supposedly supported by the evidence. And I think there's 2 main themes that come through with the evidence-supported interventions. The first is about reducing the stress and anxiety that's associated with poverty and financial strain. So here we're talking about cash transfer programs or employment programs in their various forms. So specific ones would be universal basic income, for example, or a job guarantee on the employment side, or individual placement and support programs have a lot of evidence behind them. And then the second theme has to do with improving social connection and social cohesion in its various forms. So this could be a school-based social development program. It could be certain services that reduce loneliness or improve social ties. There is a bit of evidence behind these ones. But I think when you're talking about interventions, and why we haven't included it just yet, is that it's really important how these are designed and implemented, because that can have a big impact on their effectiveness and also any unintended consequences. And so I think it's also important to have a robust, integrated and properly funded evaluation framework when implementing these sorts of interventions as well. There's a huge team of people involved in developing a model like this. I've only got a small role in this program. So there's the collaborators at the University of Sydney involved in the technical aspects of developing the model, but also the project management and stakeholder engagement. and also the stakeholders themselves involved throughout all the workshops and the other meetings, particularly the young people with a lived experience of mental health conditions, who we work with on a close basis to make sure that this is representing the system correctly. So that's all I wanted to say for this presentation. You're welcome to get in touch with me after the seminar with any other questions or comments you have about the work. That's it.
Thank you very much, Paul. I think we can all join to thank Paul for a fabulous presentation. And there's so many kind of go nuggets and take home messages. I do notice that within the chat there is one question. Do you want to unmute yourself and ask your question, Nina?
Sorry, I'm on a train. Do you mind doing it? I'm so sorry.
Yeah, that's fine. I just want to check if you want. So Nina, thank you, Nina. So Nina has a question. Your modeling shows the health and economic value of improving social determinants like employment and housing. How could I draw on this evidence to strengthen advocacy for people with acquired brain injury who are often most affected by the same factors?
Yeah, so I guess you could use the results of these studies to say, you know, when these were compared, these things here were found to be, you know, the most employment, and in this particular region in Australia, for that population in general, it was found to have these impacts and be of value. And then, you know, you'd be able to use that rationale to support action there. But I guess when it comes to specific populations, like people with traumatic brain injury, then you do need to develop a model that's specifically for that population, because there's a whole range of different factors that you might want to take into account. Say, for example, the specific risk factors and the specific associations for that particular population group. Also, if you're considering a particular intervention and determining whether that is cost effective or not, that probably has a specific design for that population, and it also probably has a specific effectiveness for that population. So we can draw generalizations between a study like this to specific populations with the relevant caveats around it. But if you know, a lot of the time you do need to make an economic evaluation that is specifically designed for a specific decision context. So it all depends on what it is that you're trying to achieve by that type of economic evidence. Sorry, Kim, you're on mute.
Thank you very much, Nina. Do you have any follow-up at all, or I can move on to Fatima and then Karen? Fatima, you want to unmute yourself?
Oh, yes. No, thank you so much, Paul. That was amazing. I probably missed the number of the sample sizes that was in that paper. But I'm just wondering, when you're trying to assess interventions, especially if it's something that, like, I don't know how the Australian Institute for Health and Welfare collected the information, especially when it's childhood experiences. Just from our recent application that we put together, obviously collecting that social information, especially from patients in the hospital, like a TBI cohort, for example, is not very easy. And you need specialized people to be able to collect that information in the context that you need. So I'm just wondering, in terms of the data that you've input into this paper, how was that data collected? Does it come from hospital? I know that there's a mandate for all of hospitals around Australia to provide their healthcare data to the AIHW, but you know, how is this information collected, I guess?
Yeah, so it's from a range of sources, but it's for the whole Brisbane population. So these models are what we call aggregate model, so it represents the entire population and the average of that population. Some of the data came from the ABS, some of the data came from AIHW, but there's no attempt to represent a specific population like the TBI population, for example. As you said, there would be, depending on which subpopulation you're talking about, there can be more or less specific issues when it comes to data collection that you have to take into account. And you've raised some of the issues for the TBI population, which are absolutely correct.
Yeah. And I'm interested in numbers. I mean, if we were ever going to do this in a TBI population where you really want to assess those factors, depending on the, as you said, in a cohort with brain injury, there's a lot of other factors compared to the ones that you've put, in addition to the ones that you've got here. So I'm assuming that the more variables you add, the larger the sample size has to be, I guess. Or is that not the case?
Yeah, well, and I mean, when you're customizing a model to a situation like that, you're also wanting to check each evidence point, each parameter, to make sure that you're representing that particular population properly. Yeah. So all of the risk factors and the associations are probably going to change. You're going to want to do a bit of research behind each one of those parameters to make sure to see what evidence there is for that particular subpopulation. Yeah, there would be a bit of work involved in adapting a model like this to a specific subpopulation. Yeah. Yeah.
Interesting. Thanks, Paul.
Karen, did you?
Are you trying to unmute yourself? Probably Karen.
Karen, would you like to unmute yourself and then ask the question?
I'm sorry, my internet's on the blink here, but hi, can you hear me now?
Yeah, we can hear you now.
Sorry, Paul, my internet is a bit iffy. Great talk. I mean, such amazing work and really difficult. I am just wondering, I was looking at the 5 or 10% improvement of childhood difficulties. I'm a paediatrician, and in my experience, and especially in the TBI population, every single one of those social determinants of health, a lot of our children that we see with TBIs have every single one. What kind of childhood difficulty intervention were you talking about to cause a 5 or 10%, or is that just theoretical? Because I think you'd have to target almost every one of those other factors, unless you're talking about early childhood intervention strategies. I don't know if my question makes sense.
Yeah, so that 5% improvement is hypothetical, like I mentioned. We haven't got specific interventions in there. It's absolutely something that we'd like to do in the future. Now that we have that model set up, we can look at adding specific interventions in there. And we also don't look at a specific subpopulation like a TBI population in the model either. But like I said, it can be adapted to look at those things. Yeah, and
but I guess
that's why it starts to become a bit more.
Yeah, in a way, it doesn't surprise me that you see such a steep curve, not only, as you said, because of the QALYs over the rest of their life, but also to improve the childhood difficulties. You're really talking about targeting a lot of those other social determinants of health. Fascinating topic. Great work.
Any more questions around the room? No? So thank you very much, Paul. I hope that, everyone get a lot out of the presentation, and there are a request to have the papers, and I paste the link of the paper in the chat already. So if anyone interested in download the paper and have a look, please do so, and feel free to reach out to Paul. He's very generous with his expertise. hopefully not create more job for you, Paul. But yeah, I would like to thank Paul again for the fabulous presentation, and I really hope that you are doing really well in your final years of the PhD, and we hope to hear from you again.
Yeah, thanks again for having me along today.
So do you wanna, Margot, do you wanna
I think
me to start?
yeah, if you wanted to share those conclusion slides, we've got a few updates for the QBIC members online.
Yep.
Feel free to do that. Thank you.
Do it again, which is technically sometimes challenging. Okay. Can you see it? Can
Yep,
everyone
looking
see
good.
it?
Yep.
Okay, cool, awesome. I'm just trying to move everyone. So I guess, you know, toward the end of the talk, and we just like to do some sort of check-in with everyone, and hopefully if you enjoy the talk and previous talk and consider to be a QBIC member, please scan a QR code here. And as you can see that the QBIC initiative is about bringing people together, whether or not you're a researcher or clinician or healthcare professional, and people with lived experience, and centralize around how we can actually improving the services and understand a different mechanism to improve services for acquired brain injury and improve outcome. So please consider to join us in our membership. And then you can contribute as well as become part of the very dynamic and growing community. So if you have any more questions, please reach out to Margot and Fatima for the membership. The other thing is very exciting is the QBIC seed funding grant scheme is now open for round 2. And the deadline is in about, I don't know, 10 days, a little bit more than that. So Sunday, 31st of August at midday. So if you're interested in, please scan the QR code here, or going to and fill in the application form. So there's a set application form, I believe, and then we're looking forward to receive your application. And one of the things is very important is non-QBIC members are welcome and encouraged to apply. So I do hope that, you know, that would encourage everyone. If you work in the space of brain injury, please do join us. So upcoming QBIC events, as you can see, there's a long list of events until the end of the year, which is in November, I assume, or more coming up. So we have the QBIC Townsville Roadshow coming up, and I believe that is to a community and a clinician, a clinical, which we will talk a little bit about it. We also have different portfolio meetings. So the stroke portfolio is meeting in 2 weeks. All members meeting. So if you are a QBIC member by then, you will receive an invitation to join. We also have, in September, we also have a workshop on advancing brain stimulation for stroke and TBI recovery. And this is an invitation-only workshop, so please send Margot an email to receive the invitation. And then we also have a TBI portfolio all-member meeting, and also on the 18th, which is, you know, more or less confirmed, I will be running an introductory to health economic for brain injury research. So hopefully I will be able to welcome a lot of you to come to the workshop. So it's a half-day workshop, you know, kind of coming toward lunch and cover lunch, I believe, Margot, maybe it's not, but you can check with Margot about that. She's my boss on this. And it will be at the UQ Brisbane City campus. So if you're interested in, please send me an email or send QBIC team an email. So we know your attendance as well as your interest. So the idea of this workshop is going to be very much a hands-on and specifically focus on brain injury. rather than a broad economic evaluation type of thing. And then in October, we have a pretty busy schedule. We have workshop for QBIC stroke and technology innovation incubator. So that sounds really interesting. I will be interested in attending. And then we have the Toowoomba Roadshow in the end of October. I've heard that the Toowoomba Roadshow has been really successful. So for any of you who are interested in, please attend. And that will actually not raising the QBIC profile, but also really actually bring a community together and continue our good work with Toowoomba. And then toward the end of October and early November, we have a Stroke Survivor Day to celebrate everyone who survived stroke, which is obviously a very big burden in our population. And it's actually, from my understanding, it's even become younger now on average. And then we have an annual symposium. And if you're interested in participate in the symposium, please send the speaker session suggestion to the QBIC team. And this is a little bit more information about the QBIC Townsville Roadshow. For those of you who might travel there or, bring in a die-in from far north Queensland, please make sure that you registered and attend this. Again, I've heard that this has been a routing success last year. And the next two virtual seminar series, we will have Sue Larasi talking about the Royal Brisbane and Women Hospital Rapid Access for Concussion Clinic. And Devi, Associate Professor Devi Mohan from the School of Public Health will be talking about post-stroke cognitive impairment. So I really look forward to that because I work really closely with Devi as well. So thank you. And I believe, is there anything that I missed, Margot? Yep. Tick the box, pass the test.
Totally passed, nailed it, Kim.
Sharing, and then I believe that Margot and Fatima have some last point to say.
Oh, we can't hear you, Fatima. You're on mute.
Oh, yes. I just wanted to thank everyone for today. Can you see my screen? Yes, great. And look, I think that the time that Paul has given us is great to give us some information around this project, mental health following brain injury, let alone other areas of disease is of interest to us. So please watch this space in terms of the projects that we're lining up for looking into this. One of the things that we would like from our members is just to take the time to let us know how QBIC has benefited you in any way, whether it's led to any additional collaborations, whether you've been introduced to anybody through QBIC. I think that gives us some insight into how we design and structure QBIC to best benefit the members and the Queensland platform in general. But at the same time, it also gives us insight into how we set up collaborations or where we can benefit you. So even if you haven't benefited from QBIC at all so far, whether you haven't met anyone or no grant applications and so forth, we'd be keen to get your ideas around gaps and challenges or areas that you'd like to see presentations from for next year as well, or you'd like to hear from people speak in a specific area. Margot will prepare it. We don't have a QR code for this today, but Margot will prepare a QR code for the next seminar so that people can just, if you don't want to speak up, you might as well just put that information or even email us. Thank you so much, everyone, for your time today. And look, please reach out with any ideas if you have them, any projects. If there are people that we don't know, we're very keen to link up with them.